go. All right. What questions do y'all have for me? Nobody has any questions. Nothing. So y'all understand 100% everything.
I have a question, but I don't think it's just like for my own, curiosity.
Absolutely.
In the book, it was saying that I'll read it to you so I won't mess it up. It says decreased placental enzyme insulinase results in reversal of the dietogenic effects of pregnancy, which lowers blood glucose levels immediately postpartum. Is that why like people with gestational diabetes kind of go back to normal afterwards?
Yep, that's exactly what it is. As that placenta separates, it decreases those hormone levels and causes it to reverse back into their, if they didn't already have diabetes, reverse back into that pre-pregnancy situation.
Okay.
Every now and then you have patients that have gestational diabetes where it doesn't end up going away, but most of the time once they give birth, within 24 hours, those high blood glucoses subside. I'll say I couldn't have told you the name of the hormone, but I knew it was hormone related with the placental separation.
That's why I read it, because I knew I would mess it up.
Yeah, I could not have told you the name of that hormone, but I knew it had to do with a hormonal separation.
Okay, one more question, then I'm done, I promise.
No, ma'am. No, you're not. Go ahead.
The infant, the heel stick.
Uh-huh.
Is the little spring form thing that they're talking about, is that like what we use to check people's blood sugar?
Yes, they're very similar. The only real difference between a finger pricker that you use for finger blood glucose and a heel stick is instead of it being a dot, it's actually a slit. It's like a blade. So it will leave a slit that's usually about 1/4 of an inch long as opposed to just a single pin prick. But it operates the exact same way where you push the button and it pokes them.
Okay, on the test that we took, I got it wrong because it was saying that the skin to skin contact was the way to alleviate the pain. That sounds pretty painful to me.
What do you mean skin to skin? Like where you put it up against? Yeah. So on the spring-loaded ones, is that what you mean? Where you actually have to push down to activate the needle?
No, it was saying to alleviate some of the pain for the newborn. It was saying skin to skin contact. That was the answer, but you don't.
Oh, that was for so the mother holds the baby against her chest. But the skin to skin contact would,
yes,
help the baby be okay.
That makes sense.
With the pain, though.
It does. So what this is, another name for this is called kangaroo care. So when we're talking about skin to skin contact, where you lay, normally a lot of the ways we do it is we'll lay baby on the bare chest of the parent, and it can be mom or dad. It's been benefits to use this with dad as well. That skin to skin contact actually will decrease pain because it's a non-pharmacological soothing measure. Even patients who have had postpartum like abnormal vital signs, things like that, skin-to-skin contact has been shown to improve vital signs and postpartum complications. So it's one of those non-pharmacological pain relief methods. We used Kangaroo Care a bunch. And that's something we definitely talk about when we talk about newborns. I know we haven't gotten a newborn yet, but
Let me see. I'll ask a question.
go for it.
Okay, so I think I was reading in the book the other day that, and I can't remember exactly what it was, but people that have placenta previa, when it was something about they don't bleed as much, or their cervix isn't closed right, or something, because it's over, like the placenta is over the cervix for such a long time, or what was that all about? I cannot remember what it was exactly, but it had to do with, because they had placenta previa, something didn't happen that other people normally have happen.
I'm not sure. That's the only thing I can think of, like, because with the way the placenta kind of sits over the cervix, it does make it, and that's why usually patients with placenta previa get bleeding during pregnancy, is where it's rubbing up against that cervix and causing irritation and causing bleeding. So I'm not exactly sure on the answer on that one. I would guess it has to do with the cervix not closing. What's that?
I'll have to look it up again to see if what the exact word was. If it was something that they didn't have or they did have, and I can't remember what it was. So
Interesting.
I will look it up again and send it to you.
Yeah, let me know, because I'm not sure about that one. My only thought is maybe they do have issues with their cervix not closing completely, or either excuse me, having issues with cervical lacerations because of the irritation from that placenta sitting near the cervix.
During lecture, did you mention that with the vaccination of mom, that she can get the rubella after delivery? Or
Yes. Yes.
Okay.
So as soon as she delivers, she can get that rubella vaccine. She just baby has to be out first, so they can't get it while they're pregnant. But once they give birth, she can get that while they're still in the hospital, and she can still breastfeed with rubella and other live vaccines. She just shouldn't conceive another baby for at least 30 days.
What about the flu vaccine? Can she receive that one?
During pregnancy or?
During pregnancy.
Yes, flu vaccines are okay during pregnancy. In fact, flu vaccines and Tdaps are encouraged. It's your live vaccines that you can't get during pregnancy. So your MMR and your varicella are your two big ones. Another one is HPV. They recommend not getting, not that that's a live vaccine, but they recommend not getting that during pregnancy as well. Good. All right, I know y'all got plenty of questions. Come on. Or do you not even know what to ask anymore? Jamaica, I saw you typing and then it went away. Did you change your mind? Oh, just kidding. It just took a second for it to populate. So bubble he. Bubble he is our, oh, you did. So bubble he is our postpartum assessment. It is a, hold on. I'm trying to pull up my stuff here. It is an acronym that helps us remember the parts of the focused assessment that are in your postpartum patient. So there we go. So when we're looking at bubble heat, it's just an acronym that helps you remember those parts that we focus on in the postpartum patient that's important to them. So we look at breasts. Most people think of that one. We definitely look at the uterus. The uterus is most important because that's most likely what they're going to have negative complications from if we don't check that or catch those complications like postpartum hemorrhage. We're looking at bowel and bladder, so they can have disruptions in bowel and bladder like constipation, urinary retention. Those are the most common ones, as well as urinary tract infections. Lochia is the vaginal discharge, so looking at color, it will progress in a certain fashion, starting with red, progressing to pink, and then progressing to white. We want to make sure it's progressing in order and not going backwards. We'll also look at amount. If they are saturating a perineal pad in less than an hour, that's concerning. That's a sign of hemorrhage. If they're having large amounts of clots or very large size clots, we'll look at that. So the color, amount, characteristics of the lochia. When it says episiotomy, that's more just talking about the perineal assessment in general. So if they have an episiotomy, we'll look at that, make sure the site doesn't have any symptoms of infection or dehiscence or things like that. But also looking at just the perineal wall in general for things like bruising, hematomas, unrepaired lacerations, things like that. Looking at when it says Holman sign, we don't really do Holman sign anymore specifically as an assessment, but it helps you remember to assess for blood clots. So looking for symptoms like calf pain and redness and chest pain and cough and things that might indicate that they have a blood clot, because these women are increased risk due to impaired mobility or increased clotting factors, or even just being in the stirrups, for example. If they were in stirrups, that pressure it puts on the legs can increase that risk. And then the last one is emotional status. So assessing for things like postpartum blues, postpartum depression, psychosis, things like that, but also part of emotional status, if they are adapting well to their role, if they are developing bonding and attachment to their infant, things like that.
What was the first kind of thing you said with the Holman sign?
What's that?
With the Holman sign, the first type of pain you said?
Calf pain. Like CALF, calf.
Okay, I heard calf. I was like, what? Okay.
I mean, you never know, but yes, calf, like the back of the leg.
When will the mom's vital signs return to normal? Or within a decent range?
So If you're talking about heart rate, so heart rate usually takes about a couple days, just because of part of their heart rate increase is from having so much extra fluid on board. Temperature is not going to be abnormal. SATs are not going to be abnormal. Respiratory rate, as that baby is, because a big part of the reason their respiratory rate goes up during pregnancy is, one, they need extra oxygen to support them and baby, and as well as their respiratory rate goes up because of baby pushing up on the diaphragm and they can't take as deep a breath. So respiratory rate usually goes down pretty quickly, you know, within a few hours. What am I forgetting? Blood pressure. Blood pressure it depends on the patient. If they have hypertension, for example, it may take a few days or it may only take a day. But somebody without any kind of abnormalities related to their blood pressure typically will only take a day or two. So not too long.
Okay. I was only asking because one of the questions that we were doing in our post quiz had the heart rate at 110. I mean, heart rate, blood pressure. No, heart rate.
Heart rate,
at
yeah.
110. No, blood pressure. I forgot which one. It was 110 for something. And I don't think I picked that, but that was the answer because it was indicating hemorrhage.
Right. Yep. So that's over. That's still at normal of that would indicate, yes, that they are having something, that they have tachycardia, so their heart is working a little extra harder. Why? And more than likely, if it's within the first 48 hours and you have tachycardia, you're going to think more hemorrhage. After 48 hours, it could be hemorrhage, or it could also be some kind of infection as well. Typically, when we're talking about infections take 48 hours to matriculate. So when you're talking about a brand new patient that just had a baby, brand new post-op, things like that, you're not good. Just like when you have pneumonia, for example, if you come into the hospital and 12 hours after you're admitted, you're tested for pneumonia. You don't have hospital-acquired pneumonia. You have community-acquired pneumonia because it's less than that 48 hours. Once you hit that 48 hours, then you're looking at things like infections, because it usually takes 2 days for those symptoms to matriculate from the exposure moment.
Okay, thank you.
Absolutely.
That's kind of dangerous, isn't it? That's about the time they are ready to go home.
You got it. Our current, and I was talking about, for those of you that were in the day class, I mentioned how the United States is one of the worst countries, one of the first world countries for postpartum hemorrhage and people dying. We send patients home in no time after having a baby, and it seems routine. You have a baby, you go home, no big deal, but the baby and the mom have potential for poor outcomes, and that's where that can, like you say, be dangerous, because that's right at that point where you still have that potential. So we do see some of those coming out because either we send them home too soon, or it goes unrecognized. I mean, my first one was born at 5 o'clock in the morning, and we went home at 6 p.m. the next day. So 37 hours. And this was with a preemie. So ridiculous.
So
nothing happened,
but that's good you're educated, because a lot of people like a preemie 36 hours.
Right.
That's crazy.
Right. And like you say, they even said in that case, they said because I was a pediatric nurse, they were willing to send her home with me because I knew what to look for as far as like hypothermia and all that. But if it was a normal baby, they would have sent somebody home, and they won't necessarily know what to look for in either, whoops, I keep knocking this folder now, in either themselves or even in their baby, what could be potential complications. There's a lot of education that has to happen in a day or two, and we are sorely lacking in our postpartum care in the United States. For something that should be so routine, there's too many people that die of something as simple as having a baby. Hey, Dominique.
I don't know if you can hear me. Can you hear me?
I can hear you.
Okay. I'm like sneaking. I'm at work. So.
Oh, my goodness.
Yeah, but it's worth it. I don't have any more patients this afternoon, so I just thought I'd join in to see what it's all about. Are we asking questions and then you're elaborating? Okay.
Whatever questions y'all got, anything y'all want to talk about. Life, liberty, or the pursuit of happiness.
I did have a question in regards to one of those focus review because I got them wrong about the heel stick. And like, I'll be honest, I didn't read before I took that focus exam. Yeah, but it just didn't make sense to hold the baby because it seemed like it would be better for them to kind of be like independent and try to get it done before clotting. I know my brain just went way left or just thought too much into the question. And the answer was to have the mom to hold the baby while you do that. It just didn't seem like it was fitting. I guess because I'm thinking about on a regular outpatient clinic setting where, you just do it and, you send the lab work off. I didn't understand it. I mean, even though I read it afterwards.
Right.
How does that make sense? I'm sorry.
So Angela already asked this one, so I know exactly what question you're talking about. So when it comes to skin-to-skin contact, what you'll also see called kangaroo care. This is considered a non-pharmacological pain measure. Now that you mentioned the fact of, like you say, you want to go ahead and get it done, pain is not always just pain. One thing that you have when you have pain is you actually have vasoconstriction as well. So if you have vasoconstriction because you're in pain, then that's going to make that cap refill stick harder to do. So not to mention the fact that they're hurting and you want to comfort them. So that is one of your non-pharmacological pain measures that you can use to make it more comfortable for baby to obtain that heel stick. Now, I will tell you most of the time, yes, when I've had my own children get stuck, they're like, whatever, hold you down, just do it. But it's really not the best way.
Okay.
Does that make sense?
Yeah, I mean, it has to make sense. I mean, I kind of understand it now, but again, my mindset was like on a different, like,
right.
Okay, well, you just get the baby and you do what you got to do, and here's your baby back. Of course, with therapeutic communication, like,
right.
Sensitivity.
Right.
Yeah.
And remember, when you're answering questions, think holistically. Like, unless there is something that indicates like a complication or something like that, think about you're caring for the whole patient. So in this case, it's looking for what are you going to do to comfort your patient as well, and that would be part of that skin-to-skin care, the kangaroo care for pain relief. Another one that we use with infants a lot that we'll talk about next week is non-nutritive sucking. So pacifiers. Pacifiers are another option that we use a lot for pain management.
And with the sweetie stuff on it.
Exactly. Yes, that stuff is fantastic.
Mm-hmm.
So if y'all don't know what Sweeties is, it's like a sucrose solution. What's that? Oh, if y'all don't know what Sweeties is, it's like a sucrose solution. It's a liquid. It comes in a little cup with a peel lid, individual use, and you dip the pacifier in it and then let the baby suck on it, and the sweetness of it acts as a comfort measure for them.
Miss Martinez, can you hear me?
Yes. I can hear you. Can you hear me?
I take my kid to dance, so could you?
What's that?
I said I can hear you.
Oh, okay.
Okay. So could you go over prioritizing patients again? Those are the ones that I have the biggest problem with. I mean, I understand,
sure,
you know, the ABC and the 5 Ps, but do the pregnancy 5 Ps come before the, the medical 5 Ps? And
so in general,
come before?
So one thing I'm going to tell you, which I mentioned in class for those of you in the day class, one thing I highly recommend you look at is I have an hour recorded lecture under introductory documents that tells you how to take a test that walks through different examples of how to pick what's more important. And one of those examples I use is about prioritization. Hold on. Let me find the slide. So I would recommend go under introductory documents, and there's a folder about test taking skills, critical thinking. It's called one of those. I know I've got a question in here about it. And listen to that, because that walks through different techniques, for example, of how to answer, like for instance using Maslow and using the nursing process and things like that. I know I've got one in here. Thought I did. Because I go through a lot of different scenarios, how to break down like therapeutic communication. Why can't I find this? I don't find it. It's delegation. Okay, so I thought I had more. This one just talks about using Maslow. It gives actually, here we go. Here's the slide I was looking for. So there's several techniques you use as you go through. Oh, let me share it. As you go through answering questions and deciding how to prioritize, what's a technique that you can use. So, for example, this gives several examples of how you can prioritize. One of these is using your ABCs and calling for help. So let's say, for example, you have a patient that's having a seizure. What do you do first? If one of your answers is stay with the patient and call for help, more than likely that's going to be your answer. If your answer is your patient is choking, what's the first thing you do? It's not going to be check for a pulse. It's going to be give the Heimlich, because airway comes first. So looking at things like ABCs and getting help with you as you need it. Another thing that you can use to determine which is your priority is Maslow's hierarchy of needs, and always think soma before psyche. In other words, your physiological needs and your safety needs are going to come before your psychosocial needs. Another one you can use is your nursing process, assess and lessen distress. For example, again, if you have a patient that's choking, then you're not going to assess if they have an airway or assess what their pulse ox is. You're going to act right now to do something about it. They're in distress. But if they are not in a distressed situation, you can take the time to assess and figure out what your problem is. For example, if they say, I'm having pain, your answer may be determining the location of their pain, for example. They're not in a distress situation. There's not something going on that's going to directly impact them if you don't act now. So this is something you can take the time to assess. And the other one I have here is infection control, because as a general rule, if you have somebody with an infectious disease and it is asking you what is your priority. Your priority, for the most part, if the patient is stable, is going to be to isolate them under whatever means of isolation is necessary depending on their infectious disease, because your big concern right then is preventing a public health problem as opposed to that individual patient. So when it comes to infection control, you want to isolate that patient. So as far as this part I was talking about with determining your prioritization with individual patients, you have these 4 patients. Which one are you going to go to first? So you always want to go with your unpredictable is going to come before your predictable. So, for instance, if you have a patient who's newly admitted with gestational hypertension versus a patient who is newly admitted without gestational hypertension, the one with has even if they're not in distress right this moment, they have a greater potential of having distress. Same thing with unstable versus stable. For example, if you have a patient whose blood pressure is 180 over 100, well, that's pretty unstable at that point. That's pretty concerning, needs to be addressed, versus you have a patient with a pain of 5 out of 10. Well, you don't want your patient to be in pain, but at that point, that blood pressure has the greater potential to have a negative impact. Another thing you look at is acute versus chronic. For instance, if you have somebody who, let's see, chronic, for example, let's say you have somebody who has a stage 3 pressure ulcer. That's not something new. That is a chronic situation. That did not happen all of a sudden overnight. That is chronic. Versus acute. Somebody, what's an example? Trying to think of what could be. Acute could be pain. So let's talk about acute versus chronic pain. If they have that pain 5 out of 10, well, that pain is acute versus the chronic wound. And then physiological versus psychological. This goes back to Maslow's hierarchy of needs. A physical need, such as in this case, you see that bleeding going on, that's more important than them crying. So things like pain is going to be more important than their emotional needs when we're talking about prioritization. Yes, new or worsening. That's a great way to put it because that indicates that it's acute. It's a change. When you have things that are changing versus chronic, stable situations, that's what you're looking at. So I would recommend go listen to that at some point, because I walk through several different examples of how you, and they're not maternity specific questions, so they're not where they're going to help you as far as the maternity part, but more how to analyze those questions of what words you're looking for and how to determine prioritization, delegation, umbrella answers where sometimes you have multiple answers that are correct, but they all fit under one answer that's like an umbrella that covers all of those aspects. So I would encourage you to listen to it. Again, it's about an hour or so, but I walk through several different scenarios, including that prioritization, because I will tell you that is a struggle for a lot of people, is prioritization and delegation as well. But they are two things that NCLEX absolutely loves, is prioritization and delegation, because especially the prioritization, that's what you're going to be using a lot in practice. You have, when you're starting out your morning, you have these however many patients. Who do you see first? When you have things going on, what do you need to take care of first? It really is a critical thinking process you'll use in practice, and that's why they love those questions so much, because it really helps focus on that critical thinking. Did I answer your question, or did I just kind of revolve around it?
Yes, you did. And
what's that?
I started to watch it, and then I started to watch that video in the very beginning of the semester, and I totally got, sidetracked with laundry or kid stuff, or so I'll go back and.
Yep. Well, guess what? You have nothing to do on Monday.
Yeah.
Y'all are free Monday or Saturday? Maybe.
I have a question,
Yeah.
Ms. Martinez. So, I was reading about the perineal tenderness, laceration, and episiotomy?
Oh, episiotomy? Mm-hmm.
Episiotomy, excuse me. And so it says that you can use heat therapies and encourage sitz baths, but I just needed to know the time frame postpartum, because I know that you're not going to want to do that right away. It says co-packs, but I just wanted like a time range for that.
More than 24 hours. So it has to be at least 24 hours postpartum, because if you do sitz baths before 24 hours, then that increases risk of infection. If you use heat less than 24 hours, it encourages blood to rush to the site, which will increase swelling and bleeding.
Okay, thank you.
Absolutely. Same thing like with a sprained ankle, for example. When you have sprains, you don't want to use heat on a sprain until at least 24 hours afterwards. I'm sorry, at least until 72 hours afterwards, because of how it brings blood to the site. And you don't want that, especially if you have the potential of a hematoma, bruising, swelling, all those things that happen in that area after all that trauma, for lack of a better term, because it really is a trauma. What questions y'all got?
Well, I am good for right now because of that one question with the heel stick. I was like
Good.
befuddled by that.
Right.
It kind of bothered me because it didn't seem like it was like the right choice. But I guess I will see you tonight at 6:30, so I'm good.
Okay, that sounds great. All right, so bilirubin. Let's talk about bilirubin. And I know we haven't covered newborn yet, but let's get ahead on it. So bilirubin is there's two different types of jaundice. There is physiological jaundice, which starts more than 24 hours after birth. That's what most people think of when they think of jaundice. You see it more often in premature infants, and sometimes it can have various causes. Breast milk can sometimes contribute to jaundice just because of breast milk does not promote the secretion of bilirubin the way bottle feeding does. So there's various different causes. Versus pathological jaundice means there's something wrong that's causing it. And when we're talking about pathological jaundice, our treatment's going to depend on what the cause is. So one example of a cause of pathological jaundice is if mom didn't get that RhoGAM last pregnancy, and this pregnancy, her body is attacking that fetus, and what it does is it attacks those red blood cells, causing them to rupture. It's causing mass hemolysis. It'd be just the same way as if you gave a patient the wrong blood type when you gave them a blood transfusion. You're going to cause a massive hemolytic reaction, which causes a release of a bunch of bilirubin as those red blood cells rupture, causing that pathological jaundice. So as far as what we look for, so the main symptom you're going to see is the yellowing of the skin. It's even easier because sometimes on babies, especially on darker nationalities, it can be hard to see the yellowish coloration. So if you look at the sclera, that's usually one of the easiest places to look for that jaundice if it's hard to tell on their skin. And then they can also test. There's a scanner they can test with where they put it on their back usually, and it scans and gives you a reading. The problem, it's not super accurate, so especially on darker toned individuals. So they will, I know with my daughter, they tried it because the doctor was like, she looks a little yellow to me, and it came up, and she's like, it's reading normal, but I don't feel like it's normal. And she did a blood test, and it was definitely not normal. So unfortunately, those scanners can be a little inaccurate, so they'll test through a heel stick with a blood test. Typically, you want it to be, once it gets to 15 is when they're going to be really concerned with possibly treating or not treating. And the way to treat jaundice in general is through the UV lights, the Billy lights is what you'll hear it called. There's a couple ways we can do this in the hospital. We have, they look like incubators, but they got the UV lights on the top, and baby sits in the incubator for usually 23 hours a day, and you strip them down in nothing but a diaper. You put an eye covering over their eyes, and they lay in that, and they absorb the UV light, which helps break down that bilirubin so it can be excreted faster. They also have for home use something called Billy blankets, which is very similar. It's got the UV light built into a blanket, so you just keep them swaddled up in this blanket that helps them break down and excrete that bilirubin. If it's not very high, sometimes they will have parents, when they go home, tell them put them near a window, obviously keeping them covered so that they don't get hypothermia or anything, but keeping them take them outside in the sun for a few minutes or near a window where they can absorb some of that UV light. So UV light helps to break down bilirubin. We use it in the hospital, and then you can use sunlight as well. What else? One thing we worry about with bilirubin levels, if they stay high and they're not treated, it can cause something called kernicterus, which is and I'll type it. Kernicterus. Kernicterus is where they are developing brain damage from that bilirubin getting into the brain tissue. So even though bilirubin is produced by the liver, this is not a liver problem. This is a brain tissue, brain damage problem from that bilirubin sitting on the brain tissue, not getting broken down. And it can cause permanent brain damage if the bilirubin is not brought down or controlled. So they'll have, usually we test for that by doing vision and hearing tests on babies. There are ways you can do hearing tests on babies besides the Moro or the startle reflex is one way you can get an idea where if you clap near their head, they should kind of startle and jump. And if they don't, that can be a sign of hearing impairment. But there's actually a machine where you put this little thing in their ear and it bounces sound waves off the tympanic membrane, and if they don't bounce back, that can be a sign of hearing impairment. There's ways to do visual testing as well. So with kernicterus, that can be a permanent complication of untreated high bilirubin levels. Is there anything I left out on that? Or anything you had a question I didn't answer on that? Okay, perfect. I wanted to make sure. I wasn't exactly sure what you needed, but hopefully that covered everything. And there are lots of babies that get elevated bilirubin levels. They get jaundice. Like my daughter, she had jaundice, and we never had to get treatment for it. I had to take her back every day to the doctor for a whole week, almost a whole week. It was like 5 days, to keep getting her levels checked. To make sure they were coming down, and I almost by the end I was like, just admit us already, because it was just daily getting those bilirubins checked, but never ended up having to get treatment. They came down on their own. So it's going to vary depending on the patient and how high they are. Hey, Alicia, did you have a question? I saw you typing. Did you change your mind? So they both help with, oxytocin and massaging the fundus both help. Massaging the fundus is going to work a little bit quicker. Plus, ideally, using non-pharmacological methods is usually a better option. So if you're standing there and you assess your fundus and it's boggy or the patient's bleeding, your first thing is going to be go ahead and massage the fundus, because that's something you can do right now that works pretty quickly. If that doesn't work, oxytocin can also work. We talked about oxytocin in labor to stimulate contractions for birth, but it will also stimulate contractions in the postpartum period, meaning it's making the uterus contract, which making it clamp down, which is going to stop the bleeding. You want a tight uterus, because the tighter a muscle is, the less open those vessels are to bleed.
So like on a test question, you would go to massaging the fundus before oxytocin, correct?
Yes.
Okay.
Yep, that's always going to be your first intervention when it talks about hemorrhage, if those are your options. Now, in a different situation, let's say instead of it just being a boggy uterus, your uterus is boggy, but it's displaced to the side, then instead of fundal massage, you're looking at bladder distension. So in that case, that would lead you to getting them up to the restroom, because when it's pushed to the side, either side, left or right, that is where that bladder is pushing that uterus off to the side. So in that case, instead of fundal massage, you would go with getting them to the restroom to void. Okay, perfect. All right, so as far as acne and hemorrhage, so acne is lack of tone. So your uterus, just like any other muscle, sometimes is not as tight as we want it to be. And the whole reason we want that uterine muscle to be tight postpartum is because you've got this big old wound on the wall of your uterus that has these open blood vessels where that placenta just separated from. And we need to close that wound. And the way we can do that is to make that muscle nice and tight. If that muscle stays relaxed, those blood vessels are open and bleeding when they're open. So if that uterus is boggy, for example, it's soft, it's not clamped down and tight, those blood vessels are open, which contributes to postpartum hemorrhage. So what fundal massage does, for example, if we have uterine acne where it's lack of tone, you got the boggy uterus and they're hemorrhaging, when we do fundal massage where you take your fist and you push down into that fundus, it irritates that muscle and causes it to constrict. Ideally, that's what it's supposed to do. It's supposed to aggravate it and cause it to constrict. So lack of tone or weak tone, where it's causing those blood vessels not to be constricted because of that loose muscle, then you irritate that muscle so it becomes tighter. Did I answer your question, Alicia, or thoughts? Okay, perfect.
I have a question about the one of the coagulopathies. The ITP. How would they know a person had that? And if they did have it, like what could they do different?
So if they have ITP, they the only way you would know if they were having like an acute ITP situation is by drawing their blood levels, and you would see that they have their platelet levels are reduced. Now, a lot of times people that have ITP, once they develop it, they're likely to develop it again. So if you have a patient that you already know has ITP, they're going to be much more concerned with watching that patient to see what their blood levels do. When it comes to what do you do about it? The only thing you can really do is give them infusions of platelets and FFP, which FFP is fresh frozen plasma. Your plasma has all your clotting factors in it, so we will give FFP and platelets. Y'all know what platelets do, of course, but by giving the FFP, it's giving them those extra clotting factors to hopefully keep them from dropping and bleeding. But platelets is going to be the number one thing. They can even, while they're in labor, for example, give them some platelets to help build up those levels to prevent that that bleeding situation.
Okay.
And ITP in general, when they're having an acute episode, you can give things like steroids, like when patient gets, I mean, not steroids, I'm sorry, immune globulin, but if it's one of those situations where you are about to give birth and you don't have really time for that to kick in, they can just give platelets for that. That's one of those unusual situations that require extra vigilance. Really keeping an eye on them to make sure they're not bleeding out, for example. So Rita is really just specifically about if you have a wound, specifically a surgical type wound. So an episiotomy would be one way, or if you had a cesarean section. So Rita is really just an acronym to help remind you of things that you're looking for when you assess any surgical incision. So you can use this with a post-op patient on a med-surg unit too. You're just looking for redness, edema, ecchymosis, drainage, and then approximation, which the approximation is a good thing. You want that. So it's not going to be every postpartum patient. For example, if they didn't have a C-section incision and they didn't have an episiotomy or laceration, then that wouldn't be part of that because they don't have a wound that you would be assessing those symptoms for, if that makes sense. So that's more specific to like your surgical incisions and things that have been cut on or torn. Skin openings. Perfect.
And Miss Martinez, during the ATI the focus review and assessments, I know there was a question, I can't quite remember, but it was regarding a medication that is administered during labor, and the side effect, it was not a medication I was familiar with, but the side effect ATI gave as an answer was hypertension. I don't know if anyone else remember what it was, but
was it to stimulate labor or to stop labor?
I think it was more like to stimulate it, if I'm not mistaken. I want to say it was, but it was not a medication that I was familiar with. It wasn't until I was going back and doing the focus review that I saw that.
Was it carboprose?
That's what I was getting ready to say, carboprose.
Yes. Yes. Can you go over that, please?
Yeah. So the reason carboprose is not the reason carboprose can cause hypertension also goes with why carboprose is contraindicated in patients that have asthma. So it's a beta stimulator. So kind of like you talk about with albuterol, it stimulates, causes tachycardia and things like that. Same thing with this. It can, carboprose is a medication that is contraindicated in asthmatics because it can cause bronchospasms, and same thing, it can cause hypertension along those same lines. So, it has to do with its mechanism of action causing that hypertension. I'm trying to think, why can I not think of the Hemabate? That's the other name for it. I was trying to think of the trade name, Hemabate. Gotcha. Yep. We use it in pregnancy as a toco stimulator. And it can cause hypertension. So anything, if you think back to when we talked about labor and delivery, we talked about toco stimulators, all those medications we talked about, like we talked about Oxytocin was the big one, but we talked about Methergin or methylorgonavine. We talked about misoprostol. We talked about a little bit about carboprose as well. All those that we talked about in labor and delivery that we can use to stimulate labor contractions can also be used in the postpartum period to contract the uterus to stop bleeding as well. So think of those drugs as just stimulating contractions, which is exactly what we want to happen in postpartum as well. We want that uterus to contract. So those meds you learn for labor and delivery for stimulating contractions for labor, remember those meds can also be used in postpartum for postpartum hemorrhage as well. Perfect. Awesome. And I know oxytocin is the drug that we really focus on the most, but the other ones you'll see sometimes as well. feel like oxytocin and mag are your two biggest maternity drugs that we give, the two big ones you see used over and over again for multiple different purposes. Know your mag. Y'all are asking some really good questions. I can tell y'all have been doing some work.
Another thing I struggled with too during the assessment last night was, I remember during lecture and everything I read, it said that if the umbilical cord was protruding for the nurse, the priority for the nurse was to insert her gloved hand to take pressure off the cord. But in this case, on the test last night when I did it, it was saying that to place the patient like in a in the Trendelenburg position and stuff, that was the priority. So I was a little bit confused about that.
Yep. So we talked a little bit about that in class not last week, 2 weeks ago. It could be either one. So it's going to depend on the context of your question. Basically, your priority that you're looking at when you're talking about umbilical cord prolapse is getting pressure off that cord. And it's going to either you're going to use your hand, like you said, some places it talks about using your sterile gloved hand to push up on baby's head, to push baby's head up off that cord to relieve some of that pressure until they can perform a C-section to remove that baby from the uterus. Other methods are either Trendelenburg, where you're putting their head down so gravity is pulling baby up a little bit, or even knee to chest, where you're having them pull their knees up to their chest, which will open up the pelvic cavity, thereby relieving some of the pressure on the cord. So any of those are correct answers. It's going to depend on the context of your question. What is an answer that's provided in the question? So when you're looking at what is the correct thing to do first with cord prolapse, it's whatever means is in the question that will relieve pressure off of that cord quickest.
Yeah, because the answers, there were both answers there. The one about the nurse inserting her hand to relieve the presenting part off the cord, and then another possible answer was that of the placing the patient in Trendelenburg. So of course I chose the insertion of the sterile hand, but yeah, so I don't know. Maybe I'll go back and look at it again and see if there was probably one word or something in there that probably I overlooked.
And another thing that you can look at that too, when y'all see multiple answers that could be correct, which one can you institute quicker that's going to work quicker? So for instance, in this case, you can reposition the patient quicker, and that's going to take more pressure off of that cord. So that would be where the Trendelenburg positioning, for example, would have just a hair of a leg up over using your hand to push baby's head up off that cord. It's those practice, and that's what I tell y'all. Keep doing practice questions, NCLEX practice questions. Whether it's ATI, the adaptive quizzing is awesome. Using that Saunders book or the Davis book, if you either one that you purchase, they're both good resources that have good online resources. Or if you have a different NCLEX prep book, just make sure you're doing practice questions that are NCLEX type critical thinking questions, because practice is the best way. While you obviously need to know the knowledge is important. Practicing those types of questions will greatly help you in the long run of learning how to apply critical thinking and how to break down those questions to figure out which answer is a little better than the other, because sometimes there is just a little bit of a difference or a certain word that they use that makes a difference. And the biggest thing NCLEX is testing you on is your ability to perform critical thinking. They want to see that even if you have, and I guarantee you, you will have questions on your NCLEX you don't have a clue about. There will be stuff on there that you have never heard of because you can't cover every single little thing that you may encounter. The biggest thing is, can you figure out how to analyze it to get to the correct answer based on what you do know? And that's what they're looking for. Because the same thing's going to happen in practice. You're going to have patients you don't know the answer for. You're going to have things come up you don't know what to do. What are you going to do about it to figure that out? Highly recommend practice questions. Even if they're not specific to whatever topic you're covering, just do practice questions. What questions do y'all have? Do y'all have any questions for me? Y'all have had some great questions. Anything I can answer for y'all? I love that y'all are coming to tutoring. Kudos to y'all. No, sorry, can't do that. You get extra credit in knowledge. I'm sure that probably sounded as corny as it sounded in my head too. No, we don't give extra credit. Exactly. It never hurts to ask. The worst thing that can happen by asking is you get told no. So it never hurts to ask. Oh, no problem. I enjoy it. Thank y'all for coming. So, for your maternity proctored exam, it is 63.3%. No, I'm sorry, 66.7. I think the 63.3 is peds. Hold on. Let me double check before I tell you wrong. I believe the maternity is 66 points. No. Now, one's 66.7 and one of them's 63.3, and now I'm like, which one's which? Hold on. Let's see. Maternal newborn. See, maternal newborn is the one that's 66.7. So you need a 66.7% in order to get a level 2, which gets you 14 points, and then a level 3 is an 80%, which gets you 17.5 points. So I know a lot of y'all are used to taking one proctored exam where they're worth 35 points total, but since we take 2, they are worth half of whatever would have been. It's still 35 points total allotted in your score for the proctored exams. It's just since we're taking 2, you get half of it. So in some ways that's a little bit better, because if you are unsuccessful, it's only 17.5 points you're losing instead of 35 points. They usually do very well, but it's definitely something you have to prepare for.
So, Mrs. Martinez, so you're saying that we get, so how many points do we get if we get a level 2?
14.
How about a level 3?
17.5.
Oh, okay. Never mind. Thank you.
No problem. And then same thing with the pediatric one. I believe it lets you close it out and come back. I believe that's what other people have told me before, but don't quote me on that one. You're talking about the practice test, I assume. Maybe just do a couple questions. Yeah, I was gonna say, I feel like people have told me that when you come back in, it'll just pick up where you left off. And one good thing about so it made me think of one thing with the adaptive quizzing. One good thing that's with the adaptive quizzing, instead of it taking you through all 400 questions in order and you end up repeating the questions over and over again, each time you go in, it actually lets you check, give me questions I haven't done before, so that way you're not repeating the same questions over and over again where it's just randomized. So that way you don't have to worry about that. You have to do all the questions at one time or you're going to get repeats. Because every time you go in, it'll let you check, give me questions I haven't had before. People have said that adaptive quizzing has greatly helped them feel better about the proctor. Okay, so are you talking about for the adaptive quizzing, Natalie? So when you go into, hold on, I'm going to share my screen so I can show you. Because it's not until after you get into adaptive quizzing it has you pick your topic. So let me pull this up.
Miss Martina.
Yes.
I also was still not able to see that link you sent me to see my exam. I still wasn't able to open it for some reason.
I don't know why, because I opened it on my end. Like, it was just a document attached.
Yeah, but like the focus review, I was able to see. Like the practice focus review, I was able to see everything on that one.
Okay. Did you scroll to the end of the document, page 4?
Yeah, no, it's just weird. Like it doesn't give me pages. Like it would just show me like 4 names of things, only 4, and then it would just be like, it would just say, I don't have it opened up in front of me because I have this opened up, but it doesn't give me like how it does usually on ATI.
It's not going to look the same as ATI because these are ones that I put in. It's just going to give you the topics of the questions.
Yeah, it just gave me 4 topics total, and it didn't say anything about them. It just had like 1 sentence of each one.
That's all you're going to see is 1 sentence. It's telling you the topic of the question.
Oh, okay, because it was just 4.
I don't know. When I pulled yours up, it was more than 4, so I'm not sure why you only saw 4.
Okay, I'll get it eventually, but thank you.
Let's see. Sure. Let me switch to student view so y'all see what I... Share. There we go. All right. So this is what y'all's ATI should look like when you're looking at your side. So when you go under My ATI, it might take a minute. Oh, I was going to say it might take a minute because I haven't been on here. When you go down to, I believe it's under Test, if I remember right. I'm not used to using y'all's side of ATI. Mine looks a little bit different. The Test. Remember, mine had it all the way. Yep, it's under Test. So when you go to Learning System RN 3.0, when you click on Quizzes, so they have either, you have standard quizzes where these are listed by topic. So you can do these as well. These have great questions. So the standard ones are just pre-made. There's no adaptive to it. It's just a set questions. There's a maternal 1, maternal 2, and maternal newborn final. So there's 3 of those. But if you go to adaptive quizzes, this is where you can pick the specific content. So when you go here, it pulls up, as you see, there's 3,000 questions. But if you go, you can click down on it's right at 400 questions. You can click on, for example, just maternal newborn, and get those practice questions, and it lets you go down here. You could even do a test mode if you want to practice, for instance, if you're worried about time management, for example, making sure you're taking the tests in enough time. You could do where it gives you a time limit. You can also do study review, which I recommend because that will give you the explanations in the middle, versus this one will give you everything at the end. So whichever way you work with, if you like better having them as you answer each question, or if you like having everything given to you at the end so you're in exam mode, you can pick how many questions you want. If you know you've got time to say do 50 questions, and it will, I thought there was a button you could click on Yes, there is. So up here, where it says question status, you can either pick all, meaning it will give you all maternal newborn questions. For example, you click down here. If you click unanswered and maternal newborn, it will only give ones you haven't answered before. So if you've done it before and you want new ones you haven't done before, or you can even go here and do ones that were incorrect. So you want to go back and review questions that you have done, but you want to look at again and see how you do. You can also pick level of difficulty, so easy, moderate, hard. Those will, and I don't have any incorrect because I haven't taken this, but under the student. But if you go under, for instance, unanswered, it will, and you click on maternal newborn, then you can click, let's say, I want to start with some easy questions today. You can click on easy, and it will give you those. So you don't want all. And then it will narrow down. So this is easy out of the 3,000, but then it will further narrow down to whatever subject you want. Does that make sense? How to find that? Or did I confuse you? Okay, perfect. I wanted to make sure. And you can certainly take the pre-made quizzes as well. Those are good. In fact, in a couple weeks, one of them, the maternal newborn final, is your homework assignment. But the adaptive quizzing is a lot more practice questions. And people have said it really helps them with the proctored exams. What questions do y'all have? Oh, you should always ask anytime. If you don't know how to find something, please let me know so I can help you find it, because I don't want you just not to say anything and not be able to find it. Because I know ATI, sometimes if you don't know exactly where to go, you're not necessarily going, and it's under learning system. So please let me know if y'all don't know how to find something. Now y'all have something to do on your clinical days, since I know you're going to be very bored on those days not having clinical, right? Exactly. That's the benefit of coming to tutoring. You get to hear those questions that that are asked, that sometimes things you didn't even think to ask, but then when you hear it, you're like, oh yeah, I wonder about that too. I agree, Natalie. That's what I always helps me retain information better, is doing practice questions. I read, like when I did my CNE exam, my certified nurse educator exam, I had a whole book. I read the whole book. I highlighted the book. I took notes from the book. I got to the end of the book and couldn't tell you a darn thing I read in the book. But then I did 2 practice tests off of the National League for Nursing website, which is who hosts the test, and that greatly helped me, more so than anything else I did. So reading and taking notes is great, and that I encourage y'all as well. When you're reading, go ahead, when we start a new section, print off those exam objectives that are located under whatever week we're taking those exams, and fill those out as you're reading, and that will help somewhat with retaining that. Good. Hopefully that will help as well. And even print off your PowerPoints ahead of time. And as you're going through your readings, take notes from the book in your PowerPoints, keep those, and then in class you can add to it as we talk about that information too. Make it almost like an ongoing document from reading to classroom, and then after class go back and read again, or at least peruse everything to see if there's something maybe that you should add to it. Hey, Yamoka, welcome. I saw you sneak in there. I understand. Do you have any questions? Okay. Let me know if you do. We've just been going back and forth answering questions right now. Any questions that y'all have? Yomoka, do you know how to find the adaptive quizzing in ATI? I'll ask you that since we were just talking about that, not to put you on the spot. Okay, perfect. I wanted to make sure. I didn't realize some of y'all didn't know how to access it. That's what I get for assuming. Y'all know what happens when you assume that maybe y'all had done that last semester. So I'm glad y'all asked about that. We won't be reviewing the test because with remote instruction. So use your ATI report. At the end, it will have the topics of the questions that you missed, and you can use that to review that information. That's okay. Yep, that's one of the perks of doing it on ATI is that you can go back and get that report where it at least lists the topics of the questions that you missed. So it helps you know what to go back and review. And then you'll have those at the end when we get to the comprehensive final at the end. Now, most of our comprehensive final will be pediatrics, but there will be a little maternity as well. You can use that to help you remember, oh, yeah, this is what I had difficulty with. This is what I need to focus on for the comprehensive final. So typically a average pupil size is usually 3+. It's gonna, I mean, if they're fully dilate, like well dilated, that's usually like a 5. Pinpoint is like a 1, so 3 is kind of that in between. Oh, do you say pupil size? I thought you said what? I'm sorry. I totally misread what what you said. Sorry about that. So you would say yes. Typically, you would say what your pupil size is. So pupils are 3+, round, react to light, they accommodate, etc. I don't know, because in fact, normally when you chart, a lot of times you'll chart pupil size. So it's under the report that you pull up. So the report that shows you, I'm used to finding them. Let me see where y'all found the report on your side. I'm used to seeing them on my side. I know where to find them on my side. Let's see. think it's under my results. Yes. So, close my results. I believe it is. Make sure that's actually pulls up what I think it's pulling up. Yes, so that's what I'm looking for. Let me show you. So, hold on, share. So it's the same place like where y'all put your reports when you do for homework. So when you go to the tab that says My Results, I'm not going to have as many results as y'all have. For example, we'll click on this dosage calculation. When you click on where it actually has that, and then when you click on Download Report, that's when it gives you, and there's probably not much of anything. This is when it gives you, and this one looks a little bit different. It'll give you the report, and normally it would have a lot more with it because I barely started on this lesson. And it's one of the old ones. But it will have this whole report, and if you scroll down to the end, it will say topics to review, kind of like it does on y'all's practice tests. And where it has that is where are the topics from the questions from your exam. But if you don't download report, it won't show you like those at the end. Yes. Do y'all have any more questions for me? Y'all have had a lot of questions. I love it. All right, if y'all don't have any more questions, I'm going to let y'all go so y'all can either get on with your day or get ready for class tonight, either way, depending on what's going on. So some of you I will see in a little bit. The rest of you I will see next week. Enjoy your weekend. Y'all are welcome. Enjoy your free weekend.